Okay, another term is complications of peptic ulcer disease. Today we'll speak about perforation and stenosis. The perforation during the peptic ulcer disease is the perforation of wall of stomach and duodenum. The risk factors for perforation are peptic ulcer or acute ulcer in anamnesis and the Helicobacter pylori infection in 60 or 70%. The classification according to the etiology, acute and chronic. Localization, perforations, cardia, subcardial, the body of the stomach, antral, prepyloric, and the pyloric, and duodenal ulcer, bulbar and postbulbar. And the classification of the clinical forms of perforation. The typical perforation to abdominal cavity and atypical. Intermentum sac. It is a posterior perforations described by Henry Monder. To the small and large omentum and to the retroperitoneal space. And combination with other complications. Bleeding, penetration, pyloric or duodenal stenosis, duodenal obstruction. Today we'll speak about classical form, typical perforation. The clinical description. The first symptom is the pain. It will be a sudden severe pain in the epigastric region, the dagger pain in the stomach. Like the dagger strike. It's a symptom of DLFR. The first 1 or 2 hours will be bradycardia due to vagal reflex. It's possible pre and collaptoid state after the bradycardia. The first position is lying on side when the knees brought up to the jawbone. Tension of the anterior abdominal wall muscles. A positive symptom of Schottky-Bloomberg, Spijarny symptom. The Spijarny symptom is the absence of hepatic dullness and percussion. The basic clinical description is described like Monder's triad. The dagger pain in the epigastric region, board-shaped stomach, and the ulcerative anamnesis, long ulcerative history. And another triad who combined with the triad Monder's triad. Distribution of hard sounds to the level of the navel. Peritoneal rubbing, same as the pleural rubbing during auscultation of abdominal cavity. And the metallic clink when inhaling is. The Instrumental diagnostics. The first is the overview radiography of the abdominal cavity to search the Levy-Jordan syndrome. Is a free gas under the dome of the diaphragm. Here is the strip of the diaphragm. Here is the liver. And here are the free gas outcomes from the stomach. During the CT scan, gas on the abdominal cavity will be here because patient is laying. And here are the free gas. And here are the stomach. And the endoscopy to see the perforated hole and to see the state of the mucosa of stomach and duodenum. Another X-ray pictures. Here are the free gas, and here too. Here is the stomach. And here is the last strip of gas. And here too. And here. And here. And another CT picture. The free gas. And the endoscopy with the giant ulcer perforation. And sometimes of atypical perforations. Perforations of ulcer. A small curvature of the stomach body into the small omentum with abscess of the small omentum. Perforation of the ulcer of the posterior wall of the stomach body into the omentum back. The posterior perforation, Monroe's perforation. In the perforation of the ulcer of the posterior wall of the duodenum into the retroperitoneal tissue, retroperitoneal space, the retroperitoneal phlegmon. But we speak today about typical perforations and the treatment. In some cases, when the perforation is not more than the half of centimeters without peritonitis in the initial stages, 2 hours from the perforation, from the moment of perforation, the perforation can be treated conservatively. And the indications of the categorical refusal of the operation, the patient recognizes same. the patient said that he doesn't want the surgery, or lack of technical capability to perform the operation. So the conservative treatment of small perforations will be the Taylor's method with the position of Fowler, this position of laying in the hospital bed with the high position of upper part of body. With the gastric tube, in hunger, with local cold, and the fusional therapy with crystallite solutions and antibacterial therapy and anti-secretory therapy. And the parenteral nutrition. And the conservative treatment will be resultative. And the surgery treatment. Elective surgeries and the radical surgery. The palliative surgery is the suturing of perforated ulcer, simple suturing of perforated ulcer. The suturing and the suturing can combine with the omental patching, with the patch of the omentum to close the wound of gastroduodenal zone. The suturing can be provided open surgery. Here the optic ulcer perforation. And the laparoscopic. Here the upper stomach and the smooth fluid who signals about peritonitis, about initial stage of peritonitis. And here the suturing of the perforated ulcer with a mantle patch. And here is the finish. The negative sides of the suturing perforation, the possibility of violation of the evacuation function of the stomach in the early postoperative period. Development of stenosis in the long term after surgery. And bleeding from the undiagnosed ulcer of the posterior wall of the stomach. It's advisable to conduct intraoperative endoscopy during the suturing. And contraindications to laparoscopic suturing. Hard to find localization of posterior wall of the stomach and duodenum. The diameter of the perforation is more than 10 millimeters. A suspicion of malignancy. Callous ulcer with rough edges. Peripheral inflammation of ulcer up to 10 millimeters. And the serochronic diseases that prevent the application of carboxypyridinone. The obstructive bronchitis, the ischemial disease of heart, the terminal stages 3 and 4 stages of colorectal cancer. And the Boy scale of contraindications. The hemodynamic instability, late hospitalization, and the presence of comorbidities. Here, this is the scale of the anesthesiologic risks. 3 stage. If the patient have the 2 factors, the endoscopic society cannot advise to perform the laparoscopic surgery. The radical operations is the pyloroplasty after the cutting of the ulcer area. You can provide the pyloroplasty to make the wide lumen of the stomach or the stomach outlet. Pyloroplasty, Haneke-Mikulich pyloroplasty, the Finney pyloroplasty, and the Jabuli pyloroplasty, like the anastomosis. We have the high stenosed ulcer. And another scheme of ulcer excision with pyloroplasty, the Judd method. And the radical resection of the stomach with anastomosis of Bilirubin 1 and Bilirubin 2. The Bilirubin 1 anastomosis, the anastomosis between the stump of stomach and duodenum. And Bilirubin 2 anastomosis, the anastomosis between gastric stump and the small bowel. The radical operations and the suturing too can combine with the vagotomy. The operation of vagotomy needs to prevent the acid production. because the acid production after the surgery is the risk factor to have a recurrent ulcers and the ulcers of anastomosis. The first type of vagotomy is a truncal vagotomy, when the trunks of the nervus vagus is cut. But this type is a damage because the function of other organs of the abdominal cavity will be not not works effectively. And the proximal or highly selective or parietal cell vagotomy is the method of choice because you cut only branches who need for acid production without cutting off the motoric branches. And the prevention of the acid production brings the low rate of recurrent ulcers. Here is the scheme of the selective proximal vagotomy. This is the branches. Branches of parietal cell. And the last complication for today, the ulcerative pelagianal stenosis. The risk factors for the development of stenosis is the prolonged ulcerous anamnesis with a frequent relapse and localization of the ulcer in the area of the pillars and suturing of the perforated ulcer in anamnesis. The three clinical stages: compensated stenosis, subcompensated, and decompensated. And the basic characteristic of these stages is the hard evacuation from the stomach, stage by stage. The compensated stage characterized in short-term feeling of heaviness in the epigastric region after eating of a normal amount of food, with frequent heartburn and pain in the epigastric region, which increases at night. Compensated stenosis have no significant changes in the values of total protein, potassium, and chloride in the blood cell. And X-ray examination is a basic instrumental method with a parallel contrast. In the compensated stenosis, the size of the stomach is normal, but with gastroptosis. Here's the gastro, not enlarged. With active lacing peristalsis. Here's the stomach movement to have a good outcome from the stomach. And here is the ulcer area. And the deformation of the pylorus. The initial evacuation of contrast suspension from the stomach is slow. Occurs later than 2 minutes, but no more 5 minutes after taking the contrast agent. And the time of complete emptying of the stomach is slowed down to 6 hours. Here is the first picture. And here the picture after the 3 hours. And after 6 hours, the old contrast will be outcome. But in normal, then without stenosis, it will be 2 hours only. But in the compensated stenosis, it slow down to 6 hours. During the endoscopy, it will be signs of catarrhal and fibrinosus esophagitis with edema of the mucous membrane and passable for endoscope of standard diameter. And the presence of the ulcer defect. The second stage, the subcompensated stage. The outflow from the stomach is slowed down more hard. The patient with constant feeling of airflow in the epigastric region, with daily vomiting of acid contents, with the remains of undigested food. The contrast pain in the epigastric region, which decreases or stops after vomiting. The frequent heartburn, which increases in horizontal position. And emission of the lower border of the stomach during auscultative palpatory examination. Auscultation of an empty stomach is denied by the noise of splashing in the epigastric region, because it will be a lot of food in the morning. Subcompensated stenosis contain the lab decrease in the total serum protein, at least 50 grams per liter. The decrease in the potassium contain 2, 3, and chlorides. X-ray examination. because the increase in the size of the stomach with the presence of liquid on an empty stomach. The lowering of the lower border of the stomach to the level of the ridges of the iliac bones. Enlarge stomach. And here is the lower border, you see. To iliac bones. Is low to entrance to the pelvis. Delay of the initial evacuation from 15 to 30 minutes, and the complete emptying is slowed down to 12 hours. The symptom of ulcerative failure. Here is the ulcerative failure of the ulcer. Deformated pylorus and enlarged stomach. During the endoscopy, there will be signs of fibrinous or fibrinous ulcerative esophagitis. Increased size of the stomach with large fragments of food, narrowing of the pylorus or duodenum, and difficult to pass from a standard diameter endoscope. The standard diameter is 1 centimeter. And the presence of an ulcer in the pylorus or duodenum. And the terminal stage, the hardest stage, the decompensated stenosis. The constant feeling of airflow in the gastric region, with daily vomiting of stomach, contains the smell of rotten eggs. The deficit of body weight up to cachexia. Frequent heartburn, belching, the noise of splashing in the epigastric region is constantly detected. The lab tests contain the decrease in the total serum protein is less than 50 grams per liter. The decrease in potassium less than 3 millimole per liter. And hypothermic alkalosis. X-ray. A significant increase in the size of the stomach. The stomach with lowering of the lower border of the stomach. Delay in initial evacuation is more than 30 minutes, and slowing of complete emptying the stomach is more than 12 hours. to 24 hours. Here is the enlarged stomach. Here are the ulcerative failure. You can see the lower border of stomach is in the small pelvis, below the iliac bones. Endoscopy, see the esophagitis, erosive changes in the antral mucosa, and the reduction of the lumen of the pylorus or duodenum. Difficult to pass for an endoscope, and the endoscope will be not allow to the duodenum. And it needs to make the capillary installation after the stenosis. And during the endoscopic treatment, we can provide the stenting of the stomach. The stenting of stomach is the palliative treatment. And the capillary installation after the zone of stenosis is need to nutritional support. And prepare the patient for the surgery. And the surgery, the subcompensated stenosis is the indication to the surgery. The subcompensated stenosis and the initial stages of the decompensated stenosis is treated by pyloroplasty with vagotomy. That is the gold standard. It's the radical surgery. Or resection of stomach. And the terminal stage of decompensated stenosis in old patients and comorbid patients with chronic diseases is treated by gastroenterostomy with like a bypass. That this operation is no treatment from the stenosis, but needs to relieve the stage of patients. And the operations for sub and decompensated stenosis in young patients without any another diseases. The compensated stenosis is and prokinetic therapy.